So first of all, for everyone that's already here, and then for everyone that's about to join, hello, and thank you. Thank you for joining us again today. Today we're going to be talking progress and pitfalls in the quest for a successful PGX program. I am thrilled to be joined by Dr. Martin Dawes, our Chief Scientific Officer, and founder of the company, and an expert in the field of designing PGX programs, particularly for large populations, and putting in all the thinking around what should your particular population, how should we approach it? How should we think about approaching it? What are some of the considerations? So with that said, today we're going to walk through a couple aspects of that. And here's the agenda in front of us. We're going to be talking about the process for identifying people within populations who are most likely to benefit from having a pharmacogenetic test, describing the details of how that is done and really what it's meant by drug-gene interaction. And then we're going to be talking about how it can be used if we really zoom in within your organization. What are the process steps you might want to take if you wanted to implement this, taking it from that abstract level down to something tangible, a step-by-step process. And we'll talk through some demonstrations of putting that in practice. Today, we're going to run this a little bit of a different style where there will be Q&A at the end, but also we're asking for questions throughout. So as Martin's going through presenting, I'm going to be feverishly interrupting him and talking over him and asking your questions to him and trying to moderate a real discussion. I think that'd be the best way we can have this session, is to have it as a discussion where we're able to walk through these issues and try and tag through any of your questions. So there is a Q&A button down at the bottom of your screen. You can click that one, we'll get them. We'll try to respond to as many as we can. If there are some questions we don't get to, which is often the case, you can expect one of us to be in touch with you within the next day or two. And with that, Martin, thrilled to get started. Let's jump in.
Yeah, exactly. Thanks very much, Rory. And just to frame this, I think I've got about 20 slides and trying to get through one slide a minute. So depending on how many questions we get thrown, we've got a half hour to 45 minutes of the discussion. Isn't that right?
Yes, I believe that's right.
Yeah. But we're always available offline as well, and happy to follow up. I mean, I know the frustration of going to talks and you want to speak to the speaker. Well, the speaker is available for anyone to contact by email and follow up one-to-one conversations. So let's get to it. The triple aim, which I'm sure you're all aware of, improving the patient experience, improving the health of populations, and reducing the cost of healthcare, is what we're thinking about when we're thinking of introducing a pharmacogenetic program. And basically, what we've done over the years of experience of doing this. Yep.
Earlier than I expected, the first interruption, but we're stuck on the agenda slide.
Oh.
There we go.
Perfect.
There we go.
We've broken it down into two phases, really, from our experience of helping organizations, the who and the when and the how. And so first thing is, this is pharmacogenetics. So could we actually just target individuals who have genetic variants that are clinically significant? Could we look at people with significant risks of adverse drug reaction? And can we look at some conditions, and people with certain conditions may benefit from pharmacogenetics more than other groups? And then the when and the how is, are you doing this at a population level? And then how are you going to get that down into your clinical teams? How are you actually going to deliver that on the ground within a 14-minute consultation or even a 7-minute consultation? So are you doing that at point of care when people are prescribing, or are you doing it when a pharmacist is reviewing the medications?
And a big part of this is assumed that there's going to be some targeting, right? So I like the breakdown, who versus when and how, but why target at all? What's the feedback you hear in terms of why we target? Why not just everybody out of the gate to match what we see a lot of in the literature, which is a lot of enthusiasm for proactive population testing?
Okay, great question, and two-part answer. One is we will do everyone. In 20 or 30 years, we'll all have this test done at birth and a whole lot of other genetic tests done at birth. And so, yes, we could do now everyone. And so, in my practice of 7,500 people, we could just go and buy a panel and do the test. The problem with that is we have a huge expectation from the people we test that we will be able to advise them on what that test means as they use their drugs. And yes, we'll have those systems in place, but we don't right today. And so there's an educational process, both of the patients having the test, but also of the healthcare professionals. And it's much easier to learn through doing a test on a few people and restricting that to a few drugs and get used to that and then gradually scale up. So 2 points. One is probably I don't have the money for everyone right now. Two is the system will be a little overwhelmed and we need to help educate people by doing gradual implementation rather than a one-stop, let's do it now.
Makes perfect sense. Thank you.
Did that slide move on?
Yes.
Great. So let's look at the WHO to test. So we're going to go for a fraction of our population, depending on how much money the organization has and the capacity of the clinicians. That might be quite a large population or a small population. But the clinical teams need to be involved right from the get-go, because the expectations of clinical teams and the education of clinical teams needs to match your implementation strategy of the pharmacogenetics. So many groups use mental health, cardiovascular disease, and pain. And you could just go for that approach, but which drugs in these groups? And there's a relatively straightforward process. You just select the drugs with the strongest levels of evidence. And so you might say, well, codeine has got great evidence. I'm going to just use, what's that pharmacogenetic test, CYP2D6? I'll use that. However, that pharmacogenetic test, while it has strong evidence for codeine, has weaker evidence for other drugs. And how will you manage that as an organization for your clinicians who say, but I've got this pharmacogenetic evidence for another drug, maybe it's an antidepressant. Is that evidence strong enough for them to put it into clinical practice? And how do you manage that? So I'll touch on that. So basically, we got three groups: those at risk of an adverse drug reaction who you might who would likely benefit from pharmacogenetics because it reduces the risk of adverse drug reaction. Those who are likely to be taking a drug with a known drug-gene interaction, and that group who have genetic variants. And just, because so many of us have genetic variants, that is a little difficult, but it raised, when we were designing this webinar, an issue that some organizations have patients who've already been tested. And why wouldn't we want to look at the information they've got? And so it may be a place to start right now in your organization. Who's already had a test, and are we maximizing that test going forward? And it might have been for Plavix, but are you using that CYP2C19 information for the other drugs where there's strong evidence for use of that? So let's just park that and leave that aside. I'll come back to it later. But it's something to bear in mind that your organization probably has got some pharmacogenetic evidence you might like to look at. So that's the big picture of these three blobs and the target population in the middle. But how do you actually do that? And we start with the basic demographics of your 1 million patients or 10,000 patients or 5,000 patients. We have to have an idea of who you're looking after. So the numbers of patients, their age, and the number of prescriptions. And the reason for that is because the more prescriptions per person, the higher the risk of adverse drug reaction. And that's a relatively easy thing to get out of claims data or prescribing data if it's available. And it gives you this sort of picture. So you now know, okay, we've got a youngish population. It might be an older population, but this one example is of a slightly younger population. You now know your rates of polypharmacy, and it could be that if you've got 1 million patients, you have 50,000 patients who are taking more than 15 drugs each per year. And you might say, you know what, while we're going to look at the pharmacogenetics, we're also going to look at that prescribing population and see if there's something we couldn't do at the same time. Because pharmacogenetics is one part of a prescribing process. And I think it's really important that the organization realizes there are other parts like the renal function, like making use of liver function, like looking at choosing wisely or deprescribing processes as one package, because it's difficult as a clinician to have, okay, this week we're looking at your prescribing of opioids. The next week it's looking at polypharmacy. Next week it might be diabetic prescribing. Could you not just have one strategy that looks at all of them together? And as a clinician, I'm getting a one package that says, these are things you might think about for your population. So then we have the drug-gene interactions. And if you're an enthusiastic like I am, then this is really fun. This graph is information about Plavix and platelet function, and it shows differences between, on the left group, one gene variant, one group of individuals who are GA rather than the GG. And on the other side, it's another group of individuals. This time it's comparing people with AA versus GG. And I get quite excited about these forest plots and looking at the evidence. But that's because we've got the university, and we've also got a company where we've got a lot of people who enjoy doing this as well. And it's hard work to do it for all the pharmacogenetic tests. But don't worry, because other groups have done some fantastic work. And so FDA, CPIC, and PharmGKB, and the Dutch group DPWG all have done a lot of that individual work of looking at those forest plots, analyzing all the data, and then coming up with lists of drugs with high-level evidence or not so high-level evidence of drug-gene interaction. And what I mean by drug-gene interaction is that you assume that you can give 20 milligrams of citalopram quite safely to an individual, and they'll have a serum level of this and an effect of that. And these are the likely side effects and the possibility of having those side effects with percentages. With individuals who've got a genetic variant, that drug may actually have a much higher level because of the metabolism of that individual. So the drug may not be being cleared out of the system in the way that you would expect. And so the person takes the 20 milligrams on the first day, then 20 milligrams on the second day, and the serum level is going up because they're not getting rid of that drug as you might expect. And that can cause harm. And in some individuals, because it may actually get rid of the drug faster, it may cause a lack of effect, like in codeine being translated into morphine. You may not see that happening. So drug-gene interactions can cause harmful effects. They can cause people not to have the expected beneficial effect. And realizing and knowing that is part of the analysis of drug-gene interactions. And I've given you some examples as below that these groups, particularly PharmGKB and CPIC, illustrate in their databases, which are all free, online, and you can get to anytime, anywhere. So genome-wide association study shows a serum level that is different with a genetic variant. And this is actually in people with poor metabolism. Two more studies show that the serum level of the drug is statistically different between these normal metabolizers and poor metabolizers. And then 3 studies show a clinically significant difference in outcomes. And obviously, as a clinician, I'm really interested in this last group. While I am interested in the serum level, if I had a best practice alert that came up and said, oh, by the way, the serum level of this drug is likely to be different because the patient has a genetic variant, I might go, that's not necessarily helpful to my clinical decision making right now. Whereas if I have a best practice alert that comes up and says, this patient may not get the benefit of this drug because they're likely to have a lower serum level, then that may actually influence my prescribing at the time. So this I will carry forward to when we actually look at how we implement. In terms of the who, we want 1,000 patients in our organization. So we've got these resources, and we tend to use CPIC as the main clearinghouse, partly because we can see instantly the level of evidence, and we can just say, let's just use level 1 evidence drugs where there is really strong evidence that using a pharmacogenetic test will result in better clinical outcomes. Then you match that list of drugs with high-level evidence against what pharmacogenetic tests may be available to you. So there does need to be a bit of back and forth between whichever company is offering you the pharmacogenetic test. However, it is very likely that with level 1 evidence drugs, any pharmacogenetic company will have those drugs and that genetic test within its first offering. There may be a few cancer drugs with high level evidence that may not be a common genetic variant, but you need to go back and forth a little bit to match your list of drugs, the pharmacogenetic variant and the pharmacogenetic test. Once you sort of, okay, well, here are the 20 drugs which actually we have a pharmacogenetic panel that would match, how many patients are taking them and what cost savings might you get? So you can look at your population data and come up with those numbers. You can create a list of conditions from those drugs. How many people in your organization have those conditions? And then you decide the subset of conditions and drugs to start with. And this is a continuous process. This is not a just one shot do it, because you might end up with 10,000 patients if your list of drugs is a little large. So you need to say, actually, we've only got 1,000 patients we want to start with, so we're going to reduce the number of drugs. And then you go back to this cycle and make sure that, okay, yeah, that seems to fit. And this is why you need the clinicians involved, because they need to be saying, yeah, well, that doesn't make sense to have that disease and this disease. It's going to be difficult to remember that these patients need that pharmacogenetic test. We've got two groups of different specialties or whatever. So it's how the clinical team is going to implement that is going to be as important as the levels of evidence and the pharmacogenetic test.
Martin, I think this might be a good place to pause for a second, because this summarizes so much of what you went through at the top. In particular, you brought up the need to balance polypharmacy, drug-gene interactions, multimorbidity when you're assessing risk. And then you've now brought up the idea of having an iterative process walking through these. How do you think of that prioritization as someone stepping through this? Is it drug-gene interaction heavy in some organizations? Is it polypharmacy heavy in others, or multimorbidity elsewhere? How would you coach your organization to think about that interplay?
Yeah, so it's a great question, because it really comes back to what are the points the organization are interested in improving. Because when you're thinking about a pharmacogenetic program, you're not just saying, well, I'm going to do this because they're doing it. You want to do it because you've got a need within your organization. What is that need? Is it because you're seeing a lot of readmissions of patients with certain, soon after discharge from hospital? Is it because your drug budget is going through the roof? Is it because your clinicians are asking for it? And you need to, maybe all of them, but then those demands, the pain points, if you like, in your organization determine your approach. So if it's a readmission problem, maybe that's a polypharmacy problem, maybe that's a reconciliation problem between discharging patients and getting their drugs to the community. It may not be a pharmacogenetic issue. There are other pain points that will clearly be a pharmacogenetic issue, the number of adverse drug reactions. And if they're a reason for high admission or readmission, then maybe pharmacogenetics for those particular groups of patients might be a way to start. So you need to look at what your organization has in the way of pain points around prescribing, and then work with that information to inform, okay, is it going to be, am I really going to be focusing on high level evidence, all these particular drugs, or am I going to be going for a very few drugs because they fit the clinical condition that's resulting in readmissions or whatever it is?
Mm-hmm. So would you say then that this process is anchored on ROI more so than it's anchored on pharmacogenetics per se?
I would take it up a level. I would say it's on patient health. Of course, there is an ROI element in it, but if you've got lots of readmissions and patients not getting well because of the treatments not working or causing harm, then that's a priority. And because it actually fits within the triple aim, addressing that will be get a return on investment. And it may or may not include pharmacogenetics. It may actually be we're not using our renal function data to predict which dose of drug we should be giving. We're not using liver function to predict which dose of drug we're giving. All need to be considered. I think pharmacogenetics helps because it's new. It is definitely effective in reducing adverse drug reactions. And it helps clinicians think about, I've got to look at all this information together. I can't just do a pharmacogenetic test and assume that my organization will reduce adverse drug reactions. I've actually got to think about, I've got to include the renal, I've got to include the liver, I've got to look at drug-drug interactions. I've got to look at the system about deprescribing and polypharmacy. So I think pharmacogenetics helps start those conversations because it's something new. And I put my hands up, and absolutely that's how we do have discussions with clinicians about prescribing in general, by starting the conversation with pharmacogenetics, but not anchoring it totally on pharmacogenetics. It's got to be other supports that inform that conversation.
Absolutely. So it really is initiating a holistic approach from end to end, from design through clinical implementation to achieve that triple aim.
Yes.
Excellent.
And it's not a simple solution. And in healthcare, there is no simple solution. But what we try and do through the education and through this sort of program is try and minimize the disruption and minimize the complexity. So, pharmacogenetics sounds very complicated. Well, how can we make it simpler so that the clinicians who can get used to it and can adopt it in one or two conditions very quickly? So you might get a report like this where you've identified where your spending is and mental health. It actually could be not spending, it could be healthcare utilization. So it could just be the number of patients. And then somewhere someone will do a calculation about how much this could save the organization if they put in a pharmacogenetic test for certain groups of patients. And this is a guesstimate. But I think it's useful to do in an organization because the CEO might think, I'm going to save 300 million by doing this. And actually, when you look at that bottom number, you might be saving 3 million. And so creating the right expectation in the organization is also really important. Covering the cost of the pharmacogenetic test will be a minimum, but there's disruption elsewhere. There's the time of education, the software, et cetera. So it has to be a little bit more than that. And just doing a calculation like this can help the organization get better expectation of what might be the savings and where might they see them. And it really helps reveal those costs because most of the time it's the drug budget that's the driver to making change in an organization, whereas the capital costs of running an emergency room or an ICU don't alter that much. So being aware of that and including that in the process is helpful.
Now, Martin, there's a few conditions up there. This may be on your next slide. There's a few conditions up there that are listed with some of these potential benefits down below. Are there some of them that you see more often, achieving most of the benefit or most of the focus that an organization might want to achieve with their
Yes, you must have seen my next slide, Rory. Yeah, you're right. I mean, I put the three up there. Mental health, cardiovascular, and chronic pain have got the highest levels of evidence for the most number of drugs. Cancer is, I'm leaving that aside. There are some really good, useful pharmacogenetic tests for cancer patients. And I would say that most cancer units are now using pharmacogenetics. So that's why I haven't included them on this slide. Mental health, I mean, that number needed to test of 6 to 7 to get a 50% reduction in depression rating scale was done by pharmacists looking at patients who had depression that failed on one drug. Cardiovascular, antiplatelets, there's a huge legal action in Hawaii who were awarded a massive amount of money because the manufacturer of Plavix didn't include enough information about the use of pharmacogenetic tests in the product monographs, which has now been changed. Statins as well. Chronic pain, I've touched on codeine before. It is one of the major areas. So these are three common areas we see people picking up and saying, I'm going to go for that, because mental health, huge cost driver, huge problem for healthcare organizations. Maybe not secondary and tertiary so much, primary, definitely. Cardiovascular, definitely secondary, some tertiary. And then chronic pain, that's across all of us. So we're all dealing with that. And then remember that, if you choose that pharmacogenetic test with strong evidence, it's going to have less strong evidence for other drugs. And then this reusability I put down there at the bottom, the Plavix, it was used in one trial for patients who had, I can't remember now whether it was STEMIs or stents, but the test could be reused in 50% of those patients for other conditions and other drugs within the next 12 months, which I thought was remarkable, actually. That reusability is something every organization ought to be thinking about. So, have I skipped a slide? Yes, I have. Phase 1, your clinical team working with your pharmacogenetic lab provider has agreed that you will start with just one condition as a trigger for a pharmacogenetic test. You've decided to go with depression in patients over 18 that have failed to respond to one antidepressant. And we work with a group that's done exactly that in Canada. In your organization that represents about 1,000 patients per year, so it's meeting your target. And this was found because you could actually identify the number of patients on one antidepressant who switched to or have added another antidepressant in 1 year. So there's a nice logic to doing your search on your prescribing data. Your clinical team has reviewed the pharmacogenetic tests and knows that there are about 10 other drugs in several other conditions that this pharmacogenetic test can be applied to. And they've decided on a phased approach, starting with depression first for 6 months and starting to include the other conditions as they get experience with the pharmacogenetic test. So that's phase 1. You've now got the who. Now, what do you do to put this into action? So you have to make sure that that CYP2, C19, 2D6, whatever test for the antidepressant drugs is usable and reusable when it's needed by healthcare professionals. You have to ensure that that report is updated with new knowledge, because I'm sorry that the information about pharmacogenetics is continuously changing, and CPIC is updating its guidelines continuously. Now, it's not every 3 months they change the depression guideline, thank goodness, but every 2 or 3 years it will be changed. And so you have to have a system that pharmacogenetic report needs to be updated. You need to have some awareness messages or best practice alerts, BPAs, during the consultation when prescribing. And we've been talking about this internally for a while. And when you've got a level 1 evidence from an international clearinghouse organization like CPIC, talking about, let's say, Plavix and the pharmacogenetic test, there's a responsibility, if that test is being done in the organization, to have an awareness message so that the clinician can never miss it. I mean, they may override it, but they don't miss it during that consultation. So how are you going to make the messages for the depression, where there is level 1 evidence for the use of the pharmacogenetics? You have to get the team involved. And so and I'll go on to this a little bit, we have ways of addressing this. You might be doing it when you're writing a prescription, but what about having the pharmacist when they're doing a medication review, and how are you going to do that? And then how are you going to include all that other information I've talked about, renal, liver, and drug-drug interaction data? So that updating of clinical recommendations is going to be an issue for every organization, unless they've got a group within their organization or a third party who can be updating any information that they're using within their electronic health record. So those best practice alerts need to be reviewed at a regular cadence to make sure that they match the current best practice guideline recommendations.
Martin, this
Yes.
piece here,
Yeah.
where we take all of that complexity of having the end-to-end holistic solution through designing it at the front, that requires a ton of evidence review. And really deep evidence review, you kind of highlighted some of the ways
Yeah.
that considering conditions matters, considering genetics matters, considering drugs matters. But now we've run up against a different consideration set, which has the setting and the actual people on the ground administering it. How does experience and the experience of the clinicians play into the design of one of these? And how do you think about what clinicians are going to be supporting this effort and finding champions or finding people that can help push it forward?
Yeah. So I think pharmacogenetics is interesting to, in some organizations, 50%, maybe even more of clinicians, depending on their disease specialty. Sometimes it might be as low as 5 or 10%. I think there are things that trigger that. One is having patients who really did badly with drugs, and then after having pharmacogenetics did a lot better. And it's like any new drug. If a physician uses a new drug on a patient, or they see one of their patients being given a new drug by another clinician and see the patient do well, that really triggers them into using that drug more often. And it's the same for a test. If they see the use of a test, whether it's renal function, liver function, whatever, or maybe a clinical exam, if they find that clinical exam really useful in caring for their patients, they will be a promoter of that. And it's the same for pharmacogenetics. If clinicians are using the test in the first round in patients where they see the benefit immediately, such as the strategy we've been talking about, where you filter it down to a group where we know that this information helps, then I think you see early adoption. Where you see it going wrong is where you have a huge panel, 50-page report, no idea what to do, and you're going, this is meaningless to me, and the patient is requiring me to do something I don't feel comfortable about. So it's making it comfortable for the clinicians, making it useful in patients where we know that there's really strong evidence for benefit, rather than a blast of all pharmacogenetic information for all patients.
Mm-hmm. Thank you.
So the next thing is having that clinical recommendation and the language, and it's so important to get the language right. And luckily, rather than trying to make this language, again, CPIC as a clearinghouse and other organizations have got great information. It could come straight from the product monograph, which actually may have a line in it about the dose alteration with a particular genetic variant. And this is an example of pain. And you can see there's a genetic variant, poor metabolizer, and the condition. And it's really important that the condition is there, because if you think about a beta blocker, if you said, well, poor metabolizer, and you need to increase the dose by 50%, for say, you were giving it for heart failure, that might be really appropriate. But if you're giving the beta blocker for migraine treatment, you're giving a much, much lower dose, and you may not that may not be an appropriate message. So the message has to be condition specific. And then it's got to be really clear. Do not select tramadol, fine. And then explains why. And if an alternative is not an option, advise the patient to report inadequate analgesia. So you've got if you can't do it, then there's a backup plan. You can see the language is very specific, and it's difficult for each organization to write those messages so clearly. So we tend to use other organizations where they've spent a lot of time in committees actually getting that sentence perfect. So these are examples of how we might present information in an inflow event. Rather strange language. It's not urological. It's meant to actually be part of I'm prescribing, I've got 45 seconds, I'm writing out the prescription, and then this best practice alert comes up. I can override it, I can defer it, I can say, come back and see me in 2 weeks, I'm going to do something different, or I can order the pharmacogenetic test if it actually hasn't been, the one on the right shows that. Or I can go to a decision support tool within the EMR. But the point is that as I'm doing something which might cause the patient harm, the awareness of that pharmacogenetic information is there to help me avoid doing that harm. if the pharmacist is doing a review, they need to have tools that can help them run through all the information. So these tools actually include the renal function, liver function, drug-drug interactions, and are designed specifically so that the pharmacist can report, go through the process, go through all the drugs, create a report for the clinicians or for themselves if they're prescribing, altering the prescription, changing doses, advising cessation, replacing drugs, whatever it may be. And they can do this, and we've got de-prescribing opportunities, pharmacogenetic information, and then warnings and other adjustments so that it's tailored to the pharmacist's workflow. So in summary, involve your clinical teams early and frequently. Select a few drugs to start with. And I gave the example of using depression as a starting point, or pain might be a starting point, or Plavix as cardiovascular starting point. Your organization probably already has data to inform you on who might benefit from this, what savings you might make, and what diseases and drugs are important to focus on clinically, what messages you might provide and for which patients. And you may already have a best practice alert system, so it's a matter of tweaking that and including the pharmacogenetics within that. What are you going to do with the pharmacogenetic tests where the drug-gene interaction evidence is less than your threshold? Say you're as an organization going for level 1, but you've got a pharmacogenetic test of CYP2D6 and it's a level 3 for this drug. And there may be, and we've found this a lot talking to organizations, groups of clinicians who say, yeah, but why haven't you got that pharmacogenetic information for this diabetic drug? And I'm an endocrinologist and I actually use this. So you have to have a way of providing that information to the clinicians, but maybe not as a best practice alert. So some sort of filter or system within your decision support that will allow that low evidence level information to be displayed for the specialists or the other clinicians, healthcare professionals who want that, but it not coming up all the time in your system. So I think that covers everything we wanted to say, and delighted to take any more questions.
That's excellent. Thank you, Martin. One thing that we skip by early on when you're talking about working with claims data or data out of the EHR is the topic of that data and privacy. So obviously there are patients involved in it. Can you talk through some of the approaches of how that analysis can be done, both within their systems or outside of their systems, while maintaining patient privacy?
Yes, absolutely. I mean, we look at de-anonymized data for organizations where we've got an ID number, but no other data whatsoever that would help us identify the patient, no addresses or zip codes or anything like that. We do have a ton of prescribing data. So we got the drugs and the coding of the drugs, the DINs, whatever it is, the dates of when they're prescribed, the cost maybe, but we can't identify people from that. And that's really important. It means that organizations, we use confidential systems for transmitting that information. And then the analysis we do produces the graphs that you've seen. And that going back to the user is completely, it's aggregated data. And so aggregating data for the benefit of the organization is well within the privacy limitations that are put on us. If we were doing this so that we could commercialize some sort of other product, that's not really legitimate. If we were going to send this off to The Economist and say, oh, look at these two organizations comparing prescribing, no, that's not on. If we're doing this to help the organization improve the care of patients, it's absolutely within the PIPA and PIPEDA and HIPAA organization restraints. So yeah, it's a good question. I think we work with organizations to make sure they don't send us any identifiers, and that works very well.
And then, as I understand it, the process can be that we work with anonymized data with, hashed identifiers, and can then pass back to an organization. a prioritized list of those identifiers so that they can connect them down to the specific members to build their program.
Absolutely. Yeah.
Yeah. And handle the outreach from there.
Yes.
So this has been an excellent session. I think now we have a final minute here for any additional questions. I see we have one just came in from Larry Westfall. What do you feel is a realistic time frame for implementation of the initiative and then time needed for ROI analysis? Excellent question.
Yes. It depends on where you are in an organizational level, but let's say that you're starting from completely from scratch and haven't even looked at your data. You need about 3 months just to get your head around the data. And that if it's not in a format or retrievable, it might be a couple of months longer. So say on the outside, 6 months for looking at who you might test. That actually you use at the same time to engage your clinician teams, get the conversations going. So it's not just doing the data analysis for 4 months and doing nothing else. So you're involving your clinical teams and you're getting them ready. And I would say 6 months is about right for that. And then 6 months for implementation. Remember, you've got to bring on a pharmacogenetic company as well. So a year for the full thing to 18 months is probably about right.
Mm-hmm. And component parts of that can be faster, right? So if you wanted to do an analysis to decide, should we go down this path before doing the full implementation, what would a time frame be for, an analysis of some de-identified patient data?
Oh, the analysis can be done in months or even weeks, depending on the structure of that data. So, I mean, we've done them within weeks. So, they've been well presented data, are really clean, and yeah, it's, the numbers of calculations that I showed you on those slides, and then that's not overwhelming. And then to produce those graphs, it can be done in weeks.
Mm-hmm. That's excellent. Yeah, it's certainly, when part of a bigger program and a bigger deployment involving labs and software, can certainly take more time, but there are pathways to do things more quickly. Where there's a good structure and a willing audience and some champions at the outset.
We have links with lab testing companies. I mean, we're lab agnostic, really important to say that up front. We don't have any sort of, we won't be trying to sell a company particularly. It's just, we have working relationships with some of them. We can help you be put into contact with these groups, and then you can make the decision. But at least you'll know that, okay, if we go with this group, then they have a link with decision support, etc. So you know that you're getting one package, and that will certainly speed up time. You're going with an organization that can create the alerts, can create the messages, can do the analysis for you. That can certainly speed process.
Excellent. Well, this has been a really good conversation. I see us running up against time. Martin, do you have any final words for the audience if they are trying to figure out, whether to proceed with the PGX program or how to think about designing it?
Yeah, it's right to us. I mean, every organization is different, and we're not going to do a hard sell. I'm an academic. I love pharmacogenetics just because I think it's really useful for patients. And I am definitely the academic side of this. I'm not going to try and sell you anything that we make, but I am going to try and help you answer the questions you have. So please contact us, and we'll try and help you have a successful implementation.
Brilliant. Well, thank you everyone for joining us. Thanks for dialing in. If you have any of those additional questions, as Martin pointed out, feel free to contact us here or contact me directly, and I can pass on a link to Martin or others on our team. We hope you have an excellent rest of your day, and we hope to hear from you soon.
Bye.
Bye.